The Honourable Minister of Health and Child Care, Dr. David Paranyatwa, the co-chairs of the Interest 2015 workshop, I would like to thank you for giving us this opportunity to share some of the perspectives on the HIV and AIDS epidemic and responses in Zimbabwe. So I'll speak about the HIV epidemic, some HIV prevention strategies, such treatment scale-up, and then a SWOT analysis that will attempt to summarize the key issues, major highlights within our programs, and what next, moving forward in terms of responding to this epidemic. So Zimbabwe is one of the countries within the sub-Saharan Africa with a population of 13 million people. The country went through a difficult socioeconomic challenges between 2001 and 2009, and this was characterized by hyperinflation. We had human resources challenges and a weakened health system. But despite all these challenges, we managed to soldier on in terms of responding to the HIV epidemic. We estimate about 1.4 million people, including children, are living with HIV, and we also estimate that about 1.1 million adults and 121 children are in urgent need of antiretroviral therapy. HIV prevalence, as alluded to earlier on, reached a peak of 28% in 1997, but we saw a downward trend to 15% in 2013. However, we noticed a disproportionate prevalence across gender, where females have a high prevalence compared to their males counterparts. The HIV decline is attributed mainly due to successful implementation of prevention programs, prevention strategies, including behavior change. Zimbabwe is one of the countries that has got very high condom use. And also we've observed through different studies that have been undertaken, there's been reduction in terms of the numbers of sexual partners. So HIV prevalence has plateaued due to improvement in terms of survival that is linked to improved antiretroviral therapy. We've also observed a 34% reduction in terms of HIV infections in the last couple of years since 2005. And so this graph illustrates those reductions within and across countries within the region. And we're very satisfied with this, but we know that a lot more needs to be done to really reduce further infections as we move towards the 90-90-90 targets. We've also observed a 57% reduction in terms of AIDS-related deaths since 2005 and across the different populations. In terms of HIV transmission, this data is based on modes of transmission studies that were done a couple of years back. And you can actually see that most of the infections are among the adults, adult population, with 20% among children. And most of the infections occur within stable relationships, stable long-term relationships. And this is something that needs to be addressed. There are also infections occurring due to multiple concurrent partnerships. And all these are facilitated by low levels of male circumcision in the country. This is an important slide from the World Bank that looks at life expectancy and the impact that antiretroviral therapy has. If you look at data from Zimbabwe, you can actually see that around mid-2000, life expectancy was around 35 years, and this has improved to 58 years. And this is mainly attributed to the antiretroviral therapy. We have a number of programs, including condom programming, which has been quite successful in the country, and we have a very robust distribution strategy with strong social marketing initiatives that are undertaken and distribution of condoms all the way down to village level. We have very effective partnerships, and I think that is one of our strengths within our programs. We have a number of partners that do different aspects of programming. Our main challenges are the relatively low uptake of female condoms, although it's fairly high compared to other countries, but compared to the male condom use, it's fairly low. And also low condom use, particularly in long-term relationships. So that is an issue that we need to address. HIV testing and counseling is an important intervention, and this is being implemented using various approaches. We're actually trying to promote community-based testing. And I'm going to talk about HIV self-testing study, which we want to undertake. PITC is one of the important approaches that we use, and we've rolled it out to many public health facilities, and that has really helped us to increase the uptake of testing, particularly among pregnant women. This has worked out quite well. But we are concerned about the proportion of people or numbers of people who know their HIV status. Looking at data from the multiple indicator cluster survey, you can actually see that about 51% of women have been tested for HIV and know their results within 12 months preceding the survey, and 40% among men. So this is something that we really need to address as we work towards the first 90 of the 90-90-90 targets. Zimbabwe is one of the countries that will be participating in a multi-country research project called the STAR project. And the goal of this research is really to increase the percentage of the target population that know their HIV status. And we hope to increase the effective use of HIV oral fluid tests for self-testing among the target populations. So we hope that we'll be able to increase access to this technology, to distribute these low-cost, quality-assured products. We hope that we'll be able to inform the demand for these products, and then we'll be able to look at the distribution models that work, targeting different populations. We hope that we'll be able to address structural barriers that exist also within our setting. So this is one of the countries that Zimbabwe will be work together with 3 other countries within the region. Zambia, Malawi, and South Africa will be participating in this huge research study. Voluntary medical male circumcision is one of our important HIV prevention strategies. And I'm not sure whether this slide is very clear, but this illustrates the timelines from the time we started having discussions around VMMC and the scale-up in terms of numbers that are accessing the services. The goal is really to contribute towards the reduction in HIV infections, in HIV incidence in the country by scaling up VMMC to 80% of the target group, which is the 13 to 29-year-old HIV negative men. So as you see that we've been trying really to work hard towards meeting the national targets, towards the 80% target. However, you can actually see that we do have constraints within the program in terms of resources to actually fully support procurement of the devices that are required and service delivery. As you see on this slide, we do have targets in terms of scaling up this intervention, but we, amidst dwindling resources, as you see, from this particular slide. Based on some modeling work that we have done, we've been able to demonstrate that we've been able to save lives through these interventions. Looking at ART and PMTCT, over 300,000 life years have been gained through the ART and PMTCT program only in 2013. So cumulatively, you can actually see that more lives have been saved due to these interventions. EMTCT is a very important program in terms of HIV prevention, and you can actually see the timeline since we started this program in 1999. There's been evolution of guidelines in the country, embracing, adapting international guidelines and new evidence. And you can actually see that option B+ has been fully rolled out in the country. And a lot of efforts have gone towards supporting this program. So the goal is really to reduce pediatric infections by 90% and an MTCT rate of HIV to less than 5% by the end of this year. So we've observed significant reduction in MTCT rate from around 30% in 2009 to about 7%. That figure has just been, is going through some validation, but around 7% in 2014. And ARV prophylaxis for pregnant women has also been scaled up. So this is a very fresh slide that I received recently, just a few days ago, and we're still going through validation of the data, but it really shows that the MTCT rate has come down. At 6 weeks, we look at 3.6%, and at 18%, the MTCT rate is at 7%. Looking at where we're coming from, we actually see that option B plus rollout has really made significant impact in terms of the EMTCT program. In terms of ART, we've also scaled up quite rapidly, looking at adult and pediatric ART. We do have high coverage, but you see it changes every year with new estimates, with new guidelines. We always find that we're moving, there's a moving target all the time. We're 80% recently, now we're coming down to 68% for adults, and for children, 45%. But in terms of numbers of people that are accessing services, we've seen tremendous increase, and the key success factors to our programs are mainly due to the use of standardized and simplified treatment guidelines and decentralization of services to almost most of the health facilities in the country. The use of an integrated approach to training. So capacity building, we use an integrated approach. The clinical mentorship program that is being rolled out to all the districts in the country, where we have multidisciplinary teams that go out and conduct mentorship visits. We also have a quality improvement project, which is embedded within our programs to improve the quality of services, and effective partnerships. As you see on each of those slides, we do have major partners that support our programs. So we're also looking at addressing pediatric ART coverage to sort of improve, and we've recently conducted a gap analysis to really look at some of those factors that are associated with low coverage of pediatric and adolescent ART, and we've actually come up with an accelerated plan to scale up this intervention. HIV/TB is one of the key interventions. We do implement collaborative activities between HIV and TB, and you can actually see that as a country we have a high rate of TB/HIV co-infection of 69%, which warrants collaboration between the two programs. You can actually see that majority of TB patients are accessing HIV services, and they're accessing cotrimoxazole preventive therapy. We've also introduced INH preventive therapy, which is being rolled out, and many other interventions to really address this dual epidemic. We do have challenges in terms of commodities. Without commodities, you can't really have an effective program. So we're always trying to resource mobilize to ensure that we do have sufficient medicines and a robust supply chain management system to support our programs. However, the supply chain management system is robust, but it's very complex, like what was presented in the morning. And we do have multiple supply chains, but we do have one national central warehouse where all medicines are stored, and they're all distributed through one sort of distribution system. So you can actually see that we are working towards mobilizing resources. We do have our own National AIDS Trust Fund, which supports our programs, and we're really thankful to the leadership to ensure that those funds are ring-fenced, to ensure that they do support our programs. 55% of AIDS levy goes towards procurement of ARV medicines. So what are the strengths of our programs? We have strong leadership and management and coordination of HIV response. We've observed a rapid scale-up of the program towards universal access targets. We have a robust and evidence-informed national strategic plans that are costed and inform the way we do programming. We do have a well-structured health delivery system. It's well-structured, yes, but there are some challenges that are there at macro level that needs to be addressed. We do have a strengthened health system through HIV investments. We've received a lot of HIV investments, but this has had effects, like spillover effects in terms of human resources for health, in terms of health management information system that is supported through HIV investments. We also have effective partnerships within our programs. In terms of weaknesses, shortages of critical health staff, and they need to motivate them to actually do what they're supposed to do. We have a high disease burden. Relatively, we have a low pediatric ART coverage, which we're trying to address. We do have financial gaps in terms of procurement of commodities, not only medicines, but even lab commodities and support for service delivery. We also have, we're trying to roll out an electronic patient management system countrywide, but most of the health facilities are still using the paper-based system, which is difficult to track all our patients. So that is something that we're trying to address. Opportunities, we always have opportunities. We anticipate some improvements in terms of the AIDS levy, and then there are other initiatives that have come to the table. There's All-In initiative, which we're actually trying to pursue. The double dividend approach, which was presented earlier on in the morning. So even as we develop our accelerated action plan for addressing pediatric and adolescent ART, we're trying to use the double dividend approach to addressing childhood issues. The DREAMS initiative, we've also embraced that initiative, and we're working towards addressing and pursuing the 90-90-90 global treatment targets. We're currently writing the Global Fund application for incentive funding, where we're looking for additional resources to support our programs. Resources are dwindling versus a very high burden of disease and numbers of people that require services. So we are moving towards trying to close the gaps as we work towards the 90-90-90 global targets. We're working towards increasing the number of people living with HIV who know their status using the different approaches that I mentioned. We want to make sure that we strengthen adherence and retention of people on treatment. I just want to mention that in one of the studies that we're doing, surveillance activities for HIV drug resistance, we observed that patients that are initiated on treatment, at 12 months of follow-up, 89.5% are virally suppressed. And that shows, for us, it means that if we try to ensure that patients are retained on treatment, we can actually, in a way, assure viral load suppression. But this doesn't undermine the need for us to really scale up viral load strategies. We're also working towards improving the quality of care for people living with HIV. So we've recently introduced a minimum standard care package, an operational and service delivery manual, which we are rolling out countrywide. We continuously support decentralization of services and integration into primary health care. And those are the different programs that we're trying to integrate. We are also trying to ensure that there are linkages between public health interventions and what happens into the community, such that when patients are discharged into the communities, there's that continuum of care to support retention and other activities. We always pursue evidence generation, and therefore this year there are a number of surveys and researches that are ongoing to really give us information about knowing our epidemic and so that we can respond appropriately. We also recently did a hotspot mapping to just identify areas where we can actually identify high prevalence, where we can actually support those interventions in order to maximize the yield and returns on the meager dwindling resources. I thank you.